Good morning, one and all. Wishing you all a very happy oral hygiene day. I would like to extend Oral Hygiene Day, celebrated every year on 1st of August by Indian Society of Periodontology, was introduced to commemorate the birth anniversary of the doyen of Indian periodontics and the founder of Indian Society of Periodontology, Dr. G.B. Shankalwal Sir, who was the first postgraduate teacher in the country to start MDS course in periodontics at the University of Bombay. This day is celebrated with the objective to spread the message of oral health and its importance and to curb the worrisome trend of neglect, which has been one of the main causes for dental diseases. Indian Society of Periodontology provides us with the opportunity to spread message of oral hygiene across the country and to benefit Indian community through dental colleges and voluntary organizations. So today, on the occasion of Oral Hygiene Day, our speaker, Dr. Nymphea Pandit ma'am, will enlighten us on the topic current opinion on biofilm management. Before we proceed, I would like to request Dr. Anagha ma'am to introduce our speaker for today.
Good morning, ma'am. Good morning, respected Dean Sir. I wish you all a very happy Oral Hygiene Day. I hereby take the privilege of introducing you all as speaker of the day. Dr. Nymphea Pandit is graduated from SCB Medical College, Cuttack in 1993. She has completed her MDS in Periodontics in 1998 from GDC Ahmedabad. She has received the Best Graduate Award by ICDRO in the year 1993. She is also the recipient of Colgate Palmolive Award and ISPPD in 1993 and Guidant Award in 2011. She is presently working as the Professor and Head, Department of Periodontology, DAB Dental College and Hospital, Yamunanagar. She has 50 international and 60 national publications to her credit and has been a keynote speaker at more than 60 forums at international, national, and state levels. She has conducted 6 workshops on piezosurgery in periodontics at Yamunanagar, Chandigarh, Nepal, Gurugram, and Alipurduar, West Bengal. She has organized many national academic programs as a part of ISP events. She has authored a book titled Concise Periodontics and written a chapter in the implant course book conducted by IGNOU, as well as a chapter in the book on bone regeneration, and has introduced a new classification for recession related to malocclusion. She is the president of Indian Society of Periodontology and is in the editorial board of the Journal of Indian Society of Periodontology and many other national journals. She has been at different posts in the IDA Yamunanagar branch, including being president in the year 2012. I once again welcome Dr. Nymphea Pandit ma'am, and I request her to continue with the session.
Very good morning to all of you. First of all, I would like to greet you all on the Oral Hygiene Day from the head office of Indian Society of Periodontology. And I feel privileged to be a part of this platform where I can share my thoughts with all of you. I would like to thank the principal of the college, Dr. Shikli, and the management of the D.Y. Patil Dental College, who have taken this initiative to celebrate the Oral Hygiene Day on this on the 1st of August, which is the birth and birth celebrations of Dr. Shankwalkar. I would like to share with you, as Dr. I think Batul Sheikh was saying, that he was the person who actually got periodontology to India. There was not a separate branch before Dr. Jinwala and Dr. Shankwalkar. They got their degrees in US and in the Indiana University. Dr. Shankwalkar did his master's in science with major in the periodontology. And these were the people who came back and started the branch of periodontology. It is it's not one of the first branches where the post-graduation was started, but the way it has grown over the last few years, we all periodontists should be very proud of this branch because it is encompassing most of the other specialties, and it's the base and the most important part of dentistry on which the rest of the branches depend. because if you don't have good supporting structures, nothing else will actually work. I'm very sorry to say that, but the basic and the foundation of dentistry should be considered at the periodontology, and all of the PGs who are on this platform should feel proud that they are the periodontists, and there is no end to the ways they can progress in this field, be it research, be it clinical experience, be it anything, and they can really make a mark, because this is a dynamic branch, and it involves the living tissues, which gives you a feeling that you're really helping the people and making them have a very functional and aesthetically pleasing dentition, which is a very important part of your overall aesthetic appearance and your personality. So with these words, I would like to start what we are today aiming at, that we should make it a pledge today that we will be spreading the oral hygiene, correct methods of oral hygiene to the masses, which is the basic idea behind celebrating this day, so that we can decrease the afflictions of periodontium in the whole society and in the whole world for that matter. I would like to share my screen. So if is it visible? Is my screen visible?
Yes, ma'am, we can see it.
So I will be talking about the current opinion in the biofilm management, and how we can make changes in the things what don't work actually at the basis, because we still see that there are a lot of periodontitis and gingivitis in the society, and where we are going wrong and what we can correct to make it have more effect on the type of management that the patient is doing. So if we look at the world population, almost 7.3 billion of the people are having some of the dental diseases or dental issues, and it's almost represents half of the population of the world, and which is really a large number. And if we look at the gingivitis, almost everyone will have an experience of gingivitis in their mouth, and it's that 90% of the people have had gingivitis or the infection of the gingiva throughout their life at one or the other time. So that is the amount of, that is the burden of the disease that we are looking at. And if we look at the more advanced these periodontal diseases, that is the periodontitis, is almost 2% of the youths worldwide are affected, and 5 to 20% of the adults are affected worldwide with this periodontitis. Now, we all know that the main cause of the periodontitis, or for that matter caries also, is the biofilm, or the what we used to know it as a plaque initially. And then when we saw that, we looked more closely at the plaque and saw how it is seen in other parts of the world, also in the other communities, like pipes under the these ships. It was same as that what was seen in other, like ponds and all that, and that's how we changed the term from the plaque to the biofilm. And we are now, because of the advanced methods of looking at these things at the microscopic or submicroscopic levels, we are able to see that these are very intimately related microbial communities, and we have been able to isolate 700 odd oral microorganisms. Of course, we cannot grow all of them, because some of them are cultivable, some of them are not cultivable, and we cannot study thoroughly the organisms which cannot be cultivated. So we may not be able to have the full information of all the organisms that are found in the biofilm. We may be having only information about 50% of them. So this is a very nicely organized community which interact with each other, and they adapt to the changes, and that is how they survive in the very adverse conditions, because they can actually change their community according to the shifts in the pH or the mechanical motion of the oral cavity. And this makes their survival possible in the most adverse conditions in the oral cavity. And if we look at the various areas that areas of biofilm, or how it is formed, then we know that the organisms which are found freely in the oral cavity are called planktonic, and which are in the community, that is called biofilm. There is adhesion first to the surface, then there is a formation of a monolayer, and they excrete the slime layer. Then there is microcolony formation, ultimately the biofilm formation, which has the channels. The channels will take the nutrition to various organisms. Then they will also drain the byproducts or the waste products from the organism, and its community is in itself a very matured state, and it's in a very organized stage which will survive there unless it's disrupted. So if we look at the biofilm from the scanning and electronic microscopic point of view, what we see is that it's a clean surface. In 4 hours only after cleaning the surface, there are small organisms seen on that. Then there is biofilm formation, and this is the organized biofilm in 24 hours. So these are the stages of the biofilm development. And if we look at the dynamics of these, what these biofilms have, that they are having cooperation or symbiosis with each other, and they share the resources that are supplied to them. They communicate with each other and share the genetic information, which is very important for their survival. They can mutate the way we are seeing that the COVID virus is mutating, and it's having new forms which are difficult to control. The same way these organisms mutate over a period of time, they share their resistance to the antibiotics, and that is how they cannot be killed with the antibiotics as a whole. So that makes them resistant to antimicrobial, and that also makes them resistant to the host immune defenses that are normally found in the body. Recently, over a period of time in 1900, this was John Hunter who gave the theory of focal infection. So the focal infection means that any infection in any one part of the body will affect the whole body. Then that theory fell into disrepute, because we saw that there was wholesale extraction of teeth that also did not help people with cardiac problems or kidney problems or respiratory problems, and that fell into disrepute. And then they said that there's nothing like focal infection theory, but that is not true. Over a period of time, with more research in this area, we saw that oral diseases do have some effect on the systemic diseases. Like there has been a strong correlation of diabetes with the oral diseases or with the periodontitis, and now we have seen that periodontal disease is considered as the 6th complication of diabetes. So this is a very strong correlation with the diabetes. A moderate type of correlation has been found with the heart disease also, and with the other respiratory diseases, and even in the Alzheimer's disease. So it's not only that the oral cavity is affected by these biofilms which are not controlled, it's also the systemic systems of the body, rest of the systems of the body that can be affected, which makes us sort of more responsible for correction of these oral afflictions, and thereby make the person more health conscious and health related. So it was first, of course, the Lowe et al. In 1960s who gave this concept that it's the biofilm which actually causes the periodontal disease. He had these oral hygienists not brush their teeth for almost 21 years. You cannot do that research now. Nobody will allow you that. And he saw that within the 21 days, if we don't brush, we do not disrupt the oral biofilm, the problem will be that there will be formation of gingival inflammation, and there will be gingivitis, and that if you remove it, there is reversal of the symptoms and gingivitis can be treated. So he was the first person who gave this theory in that. Now we have to, over a period of time, the research has given us some facts which we have to remember before we go ahead with teaching people oral hygiene, the correct method for oral hygiene, and maintaining their oral health. So number one is that we should understand that mechanical plaque control, that is brushing and removing the oral biofilm, is not properly practiced by most of the individuals. This makes us more we should be responsible for making them practice the oral hygiene in the proper method. Number second is that, as we know, chlorhexidine is a gold standard for the antimicrobial or the chemical plaque method control methods, and that can be used as an adjunct. Now, the role of antibiotics. Antibiotics as such, we should be able to say that antibiotics have a role in the control of the biofilm, but there are problems. The systemic reviews over a period of time have shown that they don't have a very significant effect. So, and the problems are others also, that there is resistant development, and you cannot ask a patient to use antibiotics for a long time. That may not be possible. So we have to rely mostly on the mechanical plaque control and maybe the additional use of chlorhexidine or any other mouthwash. So, and antibiotics, as I was telling you, is having the problem of, there's a major challenge that antibiotics do have resistance development. As I was telling you, the organisms mutate over a period of time, and the same antibiotics may not be effective for those organisms. And in this, at the same time, there have been more strains and commensal and pathogenic oral bacteria, which may not be susceptible to the antibiotics. And you cannot go on taking plaque and having susceptibility to all of these, seeing the susceptibility to all of these antimicrobials. That may not be possible. The easier would be, of course, maintaining a good oral hygiene. So first, the most important thing, what we have to first understand ourselves and then convey it to the masses, is the mechanical plaque control, which forms actually the major part of the maintenance of the oral hygiene and the maintenance of the oral health. So the mechanical plaque control basically, as we know, consists of toothbrush, interdental aids, and others. Now, we need to understand that for the maintenance of the oral health or the periodontal health, patients need to disrupt the plaque. As we know, if we have a water jet, that may not be able to disrupt the plaque because it's a very organized community, and the mechanical disruption of the plaque is the most important thing to maintain the oral hygiene. And in the periodontally healthy individuals, it may not be very difficult to reach all the areas of the mouth, and that is how we can say that they may have more chances of having a proper plaque control in those cases. But as you can see in these cases, as the complexity in the oral cavity increases, for example, you have people with malpositioned teeth, you have people with narrow arches where the brush may not reach all the areas of the mouth, you may have people with the tongue tie, you may have people with the orthodontic appliances or with prosthetic appliances. Now, the things become a bit difficult with these additional complexities in the oral cavity. People also suffer from the gag reflex. The moment they put their brush in the mouth, it happens with me also, it's very difficult to brush, and you start vomiting. And there may be very few pastes which may suit you. Otherwise, you do not, if you start vomiting and you start having that gag reflex, you will not be able to maintain a proper oral hygiene, particularly in the posterior areas. If the brush goes or a particular taste or a smell goes, you start having that gag reflex. So these are some of the complexities that need to be taken into consideration. That's why we cannot have a generalized way of teaching people how to maintain their oral health. You may have to customize it according to whatever is found in the oral cavity. So all these malocclusions or prosthetic appliances or orthodontic appliances, they actually form areas where plaque can be retained, and you need to be more meticulous, more thorough in these areas if you want a proper plaque control. So what you need to do, and another thing is increasing pocket depth. If you have an increasing pocket depth, again, the complexity increases. So what you need to do is that you need to increase the time that is taken for the maintenance. It's not that people cannot master the oral hygiene methods, proper oral hygiene methods, if they have some of these complexities in the mouth. The only thing is they may need more time, and they may need some very trained type of oral brushing methods in those cases. So, and another thing, so the most important thing is that generally what I was telling you, have to individualize, you have to customize the oral hygiene methods. You cannot have a generalized thing for everyone. For example, a person with a very smooth oral cavity and a very nicely arranged teeth, that may take just 2 or 3 minutes per sting to clean the teeth. But as the complexities increase, they all do. In the newer modern life, the people may not have that particular that you have to brush in the morning and the evening, and there's no other way you can maintain your oral hygiene. There is one thing that you need to understand, that because there is demand on the people's time, you may have to change the timings of the oral hygiene method. Just tell people that they have to disrupt the oral biofilm within 24 or 48 hours, but that can be done on any time of the day. For example, it's not necessary if people have more time in the afternoon, and if they have more time, maybe in the late, in the early morning after the breakfast or all, they need to, they will be more compliant, because then they will find that they have... Hello, can you hear me? Am I audible?
Yes, ma'am.
Okay. I thought there is some disruption. Am I audible?
No.
Yes, ma'am, you're audible.
Okay. So we need to understand that the time is very important for people. They may not have the time in the morning and evening. You tell them whenever you have time, you have to disrupt the oral this biofilm. So how much time they will need? I was telling you the time can range from 2 minutes to 15 minutes per sitting. What does it depend on? It depends upon how much is the complexity, how much is the periodontal problem, and what is the type of dexterity of the patient, how thoroughly or how effectively he can brush the teeth, and what are the different complexities, maybe some processes, orthodontic appliances. Then you need to increase the time according to whatever problem the patient has. So you should encourage the patients to clean up to the optimal level, and gradually you can, after having many interviews or many sessions with the patient, you can actually develop a normal customized oral hygiene regime for that patient. And the patient may need to clean 1 or 2 times, and on a daily basis, some patients may need even 15 minutes of oral cavity maintenance if they have complexities in the mouth. So I was already telling you that you don't need to have it as fixed times, late last night or something. If they have time in the afternoon, just tell them that one time of the day you have to clean thoroughly. Rest of the 2 times, maybe if you're brushing 2 times more, then you may not be that thorough, but one time you have to give that whatever is actually advised to the patient, 2 minutes, 5 minutes, 7 minutes. At one time, you have to fulfill that requirement. And other times you can just go on rinsing, or you can have less time if they don't have time at the other time. And that is how you can have a good compliance from the patient. Now, another thing is toothbrush design. We have thousands of designs in the market, and if one toothbrush you will advise, nowadays Oral B has created some brushes where you have like crisscross brushes. They may be slightly better effective in the maintenance of the interdental areas. But some of the studies have shown that the type of brush or the brush design is not significantly important, because it does not have any major role in the maintenance of the oral hygiene. So these are some of the methods which you may already be knowing, that we usually recommend the modified BAS method, because this is the most important method which will lead to the sulcular cleaning. This is our area of interest where the gingivitis starts, and it maintains the oral hygiene. But you may have to recommend Stillman's and Charter's method depending upon if the patient has been treated for recession or the patient is already having recession. In those cases, you may have to direct the bristles towards the teeth rather than towards the gingiva, because here the sulcus may not be there, the gingiva may be atrophied, and actually by doing the BAS methods you may be injuring the gingiva more. In those cases, you have to advise the Stillman's method, or you can advise the Charter's method in the orthodontics, or in the areas where there have been surgical intervention has been done. In those cases, you may have to advise the Charter's method. But if there are none of these problems, the most accepted and the most easily learned method is the modified BAS method, which aims at cleaning the sulcus, which is the most important part where the disease or the periodontitis or the gingivitis actually starts. So BAS method, as I was telling you, it cleans the interproximal areas and the cervical areas beneath the height of the growth and exposed root surfaces. Now, because people may not be having a very good dexterity, so with that idea, we came up with the electrical toothbrushes, and they do have some marginal advantage. they do have some marginal advantage over the mechanical type of brushing. So the first one of the electric toothbrush was given by the Benman and Wu, which is Broxodent. It was at the fourth European workshop on periodontology that this was the first time that the electric toothbrushes have been. And in the World Workshop of Periodontology in 1996, we saw that they do provide some additional benefits because they have a movement of their own. And in the BAS method also, if we are recommending to and fro type of a movement, these brushes come with the to and fro movement and the rotatory movement, and they may be more effective. But then also you have to select a particular brush for a particular patient. If you have a patient with a very narrow arch, you may have to select a round type of an electrical brush. And if the patient has problem with the to and fro motion, then you will have to have a complex type of a brush. And it does have an ease of reaching the parts of the oral cavity which may not be possible by the normal mechanical toothbrush. So these are some of the designs. For example, look at this design. This may be effective for removing the very narrow areas. These are the areas which can be, this is the brush which can be used for the orthodontic brackets. These are the brushes which can be used by a person who may be having some muscular dystrophy, or he may not be able to have his oral hygiene. These do help. They show some marginal advantage over the manual toothbrush. There are some additional advantages or additional advancements in the brushes which have been working on the principle that basically plaque is negatively charged, tooth is negatively charged, and then what happens is the calcium ions, they form a bridge between the two, and that is how the plaque attaches to the tooth surface. And if we have an ionic brush, that takes out the calcium out of it and the plaque is disrupted. So plaque can no longer attach tenaciously to the tooth structure and it gets disrupted in that area. So this is how it actually takes out the calcium ions, this ionic brush. There have been studies which show that ionic brushes are very effective in loosening the plaque from the tooth area where they're found to be organized. They loosen the plaque from that area. And another advancement is the sonic brushes. Now, sonic brushes work on a different principle. They work on the principle that there is the formation of an acoustic energy in that area. And another thing is that they cause streaming of the fluids around the teeth, and that causes cleaning. And the most important advantage is that the brushes or the bristles do not only clean in the areas where they are kept, they also reach 4 millimeters beyond the physical reach of the brushes. So this may be advantageous in the areas where you have undercuts, or you have interdental areas, or you have brackets, or you have areas where there are prosthetic appliances which have undercuts, or you can have areas where the bristles cannot reach, and 4 millimeters beyond also they will reach and they will clean. And these bristles, because they rotate or vibrate at 31,000 strokes per minute, they cause a cavitation and movement of fluid in that area, which will disrupt the plaque. So these are some additional advancements in the brush. Wherever you feel the patient is not able to maintain his oral hygiene properly, you can recommend these brushes to those patients, ionic brush or sonic brushes or electrical brushes. So in those cases, because the primary responsibility lies with the dentist. If the patient is not, I tell everyone that if the patient is not able to maintain his oral hygiene, it's the failure of the instructor rather than the patient. The patient has been having that oral hygiene throughout his life. So he's not the one who is to blame. We are not able to convey whatever we want to the patient in a proper way so that he can understand it and then implement it. And another thing is that we do neglect interdental areas. We know very well that the areas which primarily have the periodontal breakdown are the interdental areas. And these are the areas which are the most difficult to clean. And for that reason, we have to recommend some interdental cleaning methods. So if we are having, we know that there are many aids. I will be showing you the diagrams of interdental aids that are available in the market. They should not only be recommended on the basis of the type of problem that the patient has, they should also be recommended on the basis of the dexterity. you show very fantastic methods to the patient is not able to carry it out. It's better to have a less than ideal thing, but the patient is able to use it. So it depends upon the dexterity of the patient. We generally have seen that interdental brushes are more accepted by the patient rather than the floss. Floss seems to be a more difficult thing to maintain, but it's not possible to recommend floss to everyone, because floss basically is recommended only in the areas these interdental brushes, because floss is recommended to those people where there are not very open interdental spaces. If you use interdental brush in those areas, that will not be able to fit in those areas. So we cannot replace floss with the interdental brushing of the patients. But in the patients who have some interdental space where the interdental brush can use, patients find it more easy to adapt to this type of brush rather than the floss. So if you have a larger space, you can actually recommend the single ducted brushes, and you can also have the patients use these interdental brushes or these under the processes or whatever the impediment to the oral hygiene over there is. Recently, because it may be difficult for patients to have use floss or interdental brushes, we recently have in the market the micro brushes, which look like those brushes which are used in the operative dentistry for applying the bonding agent to the teeth. So these type of micro brushes have come, and they are very effective in disrupting the subgingival plaque in those areas. So normally what we recommend is that if there are closed spaces, then we have to prescribe the floss. There are slightly bigger spaces that there is loss of the interdental papilla, then we can use the proxa brush and a wider brush, because the bristles should be able to clean both the parts, both the mesial, the distal mesial of this tooth and the distal of this tooth. So the width of the interdental brush should be such that it's able to disrupt the plaque on both sides. Now, how do we? Now we have had 5-6 sessions with the patient, and we are really don't know whether the patient is able to maintain his oral hygiene. We have to recall him very frequently. So how do we do that? At the patient's place, you can prescribe disclosing agents, and the patient can have an idea where he is lacking in his oral hygiene. For example, if the disclosing agent is found in these areas, then he will be able to brush better in those areas. And that can be assessed by the clinician also by the disclosing agents. Additionally, the clinician can also look at the inflammation and the bleeding index and modify the oral hygiene method so that it's able to maintain the oral hygiene in a better way. Now, we have already talked about how the mechanical methods work and how the interdental aids work. Now, what does the literature say? There was a systematic review that was performed whether the mechanical plaque control is effective in the removal of the plaque, and for that matter, control the gingivitis. So about in the Medline and PubMed, almost 3,223 titles were seen that we found out that if we give a single instruction, this is what we always emphasize, that the single instruction of oral hygiene is not going to work. You have to give multiple appointments to the patient and make him understand what is the importance of the oral hygiene and how he can do it efficiently with more time. And you have to do brushing with it's called a mindful brushing, that you have to not think about anything and just go around with the routine things and do the brushing. You have to be there and you have to think about that. Did I clean all the areas of the mouth, and did I clean the tongue? Did I clean the occlusal surfaces? So single instruction is not going to help. So all these titles, a systematic review, usually actually prove that the single instruction does not work. There was another study which was a long-term effective plaque control on the tooth mortality, caries, and periodontal disease. And generally what we say that if it's the loss of bone is 30%, 50%, the prognosis is very bad. But these studies have proved that the maintenance is the most important thing. Even the teeth in a very bad prognosis or poor prognosis can be can be there in the oral cavity if the maintenance program is followed very nicely. So these studies do prove that we should try our maximum best to save the teeth, but at the same time have very frequent recall visits until the time when the patient will understand what is the importance of oral hygiene and how he can have functional teeth throughout his life. Another study which was carried out, it was a systematic review of 2,179 titles and abstracts, and almost 132 full articles were found. And what it tried to do is that this is for the removal of the oral hygiene, that is performed this systemic professional mechanical plaque removal. Now, we think that if the patient is not able to understand what we are trying to do, we are recommending him professional mechanical plaque removal. But how frequent can that be? We cannot replace teaching the patient proper plaque control methods, which he can do at home more frequently than whatever we are doing. Even these studies prove that without oral hygiene instructions, even professionally, removal of the plaque is not effective. So it lays emphasis on the oral hygiene instructions more than what you are doing at your office or your clinic. So even if you are very frequently doing scaling at root planing, if you are not recommending the oral hygiene instructions and you are not reinforcing them, then also you can have breakdown of the periodontal tissues, and it can lead to the periodontal diseases ultimately. So, and this was another study which I was telling you that these power toothbrushes do have a marginal advantage over the manual toothbrushes, for that matter. And for this part of my presentation, I would like to say that it is important to have proper oral hygiene instructions for the patient, and do take some time to make him understand the importance of how effectively he should maintain his oral hygiene if he wants to enjoy the fully functional dentition for his life. And he should be made aware of the fact that if there are complexities in the mouth, then it can take almost 5 to 10 minutes for his oral hygiene methods, or it may take, even in the very complex cases, even 30 minutes. And if you do not have reinforcement, whatever treatment you do, it's not going to be effective. And over a period of time, the patient may lose teeth, and he may lose actually confidence on you also. So with this idea that this was a frustrating experience, that patients, even on repeated oral hygiene instructions, they did not maintain the oral hygiene. So with this idea, many other measures were taking up, because we then thought that why don't we have a method whereby the oral hygiene is itself maintained and there is not much onus on the people to maintain it. So in 2010, we have this study from the JDR that recommended use of nanoparticles to control the oral biofilm. This is not available in the market. We still have to rely on our oral hygiene methods. It may, in the future, there may be some ways where we can have these nanoparticles loaded with the anti-adhesive agents which can disrupt the plaque, and it may be easy for patients to maintain their oral hygiene. This is how it works. Small particles or nanoparticles of silver, copper, zinc, silicon, and their oxide, and they were seen to have antimicrobial effects. And these may have been incorporated in the mouthwashes so that oral hygiene can be maintained, or there can be disruption of the plaque from the teeth and the cavities. So these in the mouthwashes, dental pastes, and this is still in its research period, and we are not sure whether they can be developed, because ultimately their activity in the oral cavity is very less. Another method of maintaining oral hygiene that has been recommended is lasers. In the American Academy of Periodontology says that there is not much evidence to maintain the oral hygiene by the lasers. So this is also in its initial stages, that we can control the biofilm by the lasers, that too for a longer time. For a shorter time, many of these methods have given some very positive results, encouraging. But over a period of time, we have seen that we can't do it very repeatedly, and that's the reason that they cannot be recommended as a primary method of biofilm control in most of the populations. Another way is that there is a photodynamic therapy. Photodynamic therapy basically means that a dye is activated by the light, and that leads to the killing of organism, or it has antimicrobial effects. Now here the advantage is that we are not using antibiotics. So there is no problem of developing the resistance. It's the dye which releases the oxygen, the singlet oxygens, which may be having the bacterial destruction, and we don't have to bother about that we are using an antibacterial which the organisms may develop resistance to. So this is another area where we can have a research over a period of time, and we can have. So there are two ways of developing this, that dye is at a photosensitizer, or the dye is at a ground level. It's excited by light, it goes and it creates the radicals, free radicals, and ultimately leads to the killing of the organisms, and that is how it has antimicrobial effects. So this is another way which is called as the periolase. It is biolase. This was developed over a period of time with the lasers, and it has the potential to deliver laser energy to disease root surfaces, and it's effective because it does go to the areas where the toothbrush cannot reach. For example, it creates a halo around the laser tip, and that energy on moving will go beyond the area where the mechanical toothbrushing methods will appear. So this can be used in the periimplantitis also. You apply a dye on the areas where the teeth are affected. For example, you can see the bone loss in that area, and you want to treat that, you want to disinfect that area. And after debridement, you want to have an antimicrobial effect in that area to eliminate the bacteria. So you apply a dye, then you apply the photosensitizer light, and then you clean that. And this is expected to heal in a better way than if that is not used. There's another advancement in that, that if we have nanoparticles, and that is based upon the photodynamic therapy. So these are the polymeric substances, nanoparticles of PLGA, and have been used as a drug delivery system, and they have been used with the photosensitizers. The advantage of these nanoparticle-based photodynamic therapy is that it has low toxicity, and it acts very rapidly in the whole area. So there is another method of controlling the biofilm. We know that normally the oral bacteria, they live in the symbiosis. It's only after the changes in the local milieu that some of these bacteria, for example, P. gingivalis, becomes very pathogenic, and it causes creating the environment for the development of more of the pathogenic species. And that is what we know as a keystone pathobiont hypothesis. So a concept of this was that why don't we replace these pathogenic organisms with some more health-related organisms? And that is where the concept of probiotics comes, that we replace the pathogenic bacteria with the bacteria which are actually helpful, or which are beneficial for the oral cavity. So many bacteria have been seen to have such an effect, so that if we have these probiotics, or lactobacillus is one of the organisms that can replace. And what it does, that it forms a layer on the surface of the teeth, and it does not allow the unfriendly or pathogenic bacteria to colonize or to adhere to the surface. So that is how you can keep the pathogenic bacteria away. So this is one concept. Again, the problem with the probiotics is, for example, we have oral lactobacillus strains. They have antimicrobial effect against AA and porphyromonas, gingivalis, and all that. The only problem with these type of management of biofilm is that these bacteria do not remain there for a longer time. They have short-lived effects. So this is what you can know, that this has antimicrobial activity, colonization resistance, immune effects, influences the enzyme activity. So these are the various modes of action of these probiotics, which can actually disrupt, which can actually not allow the pathogenic bacteria to colonize on that area. But the problem is that these may not be having a long-term effects. they have been seen to be effective because they do decrease the levels of the interleukins or the pro-inflammatory mediators, and that is how they act. But that's what I was telling you, that they are temporary and the levels return to baseline after the probiotics were withdrawn. So they do have good beneficial effect, but that is very short-lived. That is the problem. There is a concept of vaccine in most of the diseases. That the problem with the periodontal diseases is that these are polymicrobial and we cannot have vaccines against 10 different type of organisms. And another thing is that these organisms are actually endogenous. This is not something like we have a cholera vaccine, we have a BCG, we have vaccines against the other diseases where there is an exogenous organism which is coming. This is an endogenous organism which is actually growing more than the beneficial organism. So the vaccine was initially devised, but that was found not to be very effective in these cases. So that is where the research related to the vaccine actually ended, and we don't have much evidence for any beneficial effect of these immunization techniques. I will have a brief this thing about your scaling and root planing so that we can have people with who do not are periodontists can at least manage the patients who do not need surgical intervention. So scaling and root planing, the main idea about talking to you about this is that if the patients have only gingivitis, we do scaling only. If they have periodontitis, then only we can do root planing and we can do surgeries. So mastery of these skills is essential, and I should tell you that subgingival scaling or root planing is one of the most demanding and one of the most difficult procedures in the dentistry, because it's basically a blind technique where you cannot see and you have to develop the tactile sensation in your hands to reach the areas which cannot be seen with the eye only. So the most important thing in doing or excelling at these skills is the detection technique, how you have to first detect where it is, then only you can remove it. So there are visual examination, which is not effective in the subgingival areas, but that also you need good lighting and a clean field if you want to see that. Then you have to do the tactile exploration. Now exploration is only done with the explorer, not with the probe. Probing is done for the measuring and locating the pockets. So you have to develop good tactile sensation. And there are some advanced methods of detection of the calculus. One of these products is the subgingival, which is developed by the Salt Lake City and out there. And this equipment is called as Detectar, where automatically it detects the subgingival calculus, and you can do the root planing over there. How it does that an optical fiber is converted into an electrical signal, and which is then made available on the screen, and you can see whether the calculus is present in that particular area or not. So another way is perioscope. This is a small, like you have endoscope, you can have a perioscope. It has a magnification of 224 to 48x. It's along with the device, which goes, it's like with the probe, it goes inside and you can actually see it. But all these equipments are very costly, and if you develop the tactile sensation, that will be much cheaper. So the extent of root planing, how much root planing you should do. Basically, we believe in the concept that the bacterial toxins, they do not penetrate deeper. They are just 4 μm onto the surface. So you do not need to remove a lot of cementum, because if you remove a lot of cementum, that will ultimately lead to the sensitivity of the tooth. So they are just adhering, toxins adhere to that, and it makes sense to just debride it on the surface only, not go very deep and not actually remove all of the cementum and expose the dentine, which will definitely lead to the dental hypersensitivity. So though another thing what patients actually feel is that they feel that the mechanical methods of plaque removal or the calculus removal are very hard on them, because there is a lot of lateral pressure on that, and they feel that it's not. With that concept, the ultrasonic scaling came. But one thing is important to remember is that even if you are using ultrasonic scaling or you are doing ultrasonic scaling, do use your instruments, because you cannot have tactile sensation with the ultrasonic scalers. You can have that only with a probe or with the manual instrument. So 70% of this can be done with ultrasonic scaling, but 30% of this has to be done with the hand instrumentation. That's important. Ultrasonic scalers are important from the point of view because they cause acoustic turbulence and cavitation, and that disrupts the plaque in that areas. And it's unidirectional. It has its ultrasonic waves. This turbulence, this turbulence causes the disruption of the plaque, and you can have a cavitation effect, which ultimately leads to the loosening of the debris in that particular area. So you can use these ultrasonic instruments for the debridement of calculus stains, particularly because stains are very difficult to remove with the hand instruments, and you put a lot of lateral pressure on the patients, which is not very well taken up by the patients. And you can use this in surgical when you are doing surgical intervention. So while you cannot use it, unshielded pacemakers, which are not used now, so you don't have to care much about that. You cannot use these scalers on the titanium implants or demineralized root surface, where it will lead to the increased hypersensitivity, or you cannot use it on the patients with immunosuppression from the chemotherapies, because in these patients, you may actually be pushing the bacteria and causing bacteremia. So you cannot use it in all the patients. You may have to use mechanical methods in these patients. So these are some of the contraindications. The advantages with the mechanized methods is that you don't have to sharpen the instruments. The hand size is big, so you can actually give small movements and reach all the areas of the cavity. It has a water lavage irrigation, so it disrupts and takes out the plaque from that area. And it has a less chance of stress injuries, because the removal of the calculus depends upon the vibrational capacity of these mechanized instruments. So this has been used with the diode laser also. And if we want to see what are the effects, of course, if you do not use ultrasonic scales in a proper way, that will lead to the cracks in the enamel or in the root, and that may lead to more plaque accumulation. Actually, maybe doing more harm to the patient if you do not use it with the recommended method. There is another concept of full mouth defect disinfection. What we used to think that if we do full mouth scaling and at the same time ask the patient to use chlorhexidine, at one time we are cleaning the whole of the mouth, and that will not lead to the recolonization from the areas which we might not treat. For example, if you are using quadrant-wise scaling and root cleaning, the other areas of the mouth may actually have the bacteria which repopulate. So with that concept, develop the full mouth disinfection. What it consists of, that you do full mouth scaling and root cleaning within 24 hours. And you ask the patient to use chlorhexidine mouth rinsing, twice daily tongue scraping, spraying and this chlorhexidine in the tonsil, and repeated after 8 days. But what we found out is that there was not much difference if you do quadrant-wise scaling and if you do full mouth scaling. So it is not a very novel method. It was introduced with the idea that it's a very novel method of maintaining the oral hygiene, but then it did not come up to that level. There are some polishing methods. Now we sometimes feel that why we have to do repeated subgingival scaling is because we are leaving some of the areas which are rough and which actually attract more of the plaque and which lead to the adherence of plaque more, because we are creating some rough areas. With that concept came the idea of using subgingival air polishing, which may smoothen the areas and not allow the plaque to be retained in that area. So these are some of the systems that were used for the air polishing system. So what it basically does, that the pressurized air is taken up in this method, and there is the air and the powder are mixed, and these are the combination of these particles, and it actually leads to the polishing of the tooth surface. So this is another alternative method, and that is how these abrasives will lead to the polishing of the tooth surface. So what our aim should be, but that did not lead to the very good results. So calculus removal and not smoothness should be our aim. And it might be more prudent in such a case to stop short of perfect smoothness. It's not necessary to have a smoothness. You have to tell the patients to maintain oral hygiene, and you can reevaluate. And if you find that it's not working, then you can go for the more polishing systems. Another is, this is the last part of my presentation, is about subgingival irrigation. Actually, this type of oral care method was introduced mostly by the Johnson & Johnson, and these were the equipments that were given. And what we are trying to do, that we are trying to deliver the chlorhexidine in the subgingival areas. If we are using chlorhexidine as a mouthwash, we're only targeting the supragingival areas. But if we have these irrigation methods, we are basically delivering the chlorhexidine to the areas where there is more plaque retention and where the mechanical plaque control cannot remove that. So it's actually aimed, or the rationale behind this is to reduce the pocket microflora so that we can prevent the initiation of the periodontal disease, or we can facilitate their reduction. So irrigant in these cases will penetrate almost 75 to 93% of the pocket, and they will be removed by the irrigation method. So these are some of the irrigation. It can be done with the normal syringe by the professional with a big cannula, and it can be done at home by these methods. So what does it do is that these methods of delivery of the delivery, they are a significant aid, and they significantly reduce gingivitis and calculus formation. They were found to have effect on that. And studies have shown that the jet tip can reach some gingival areas, and which is basically the area which is inhabited by the periodontal pathogens, because that is a very contained area where the organisms can grow. And it has been shown in the recent studies that diabetes and other areas, they can use these dental water jets to irrigate the area and control their periodontitis. And we have also carried out a study in our department, and we found out very positive results. This was a study design where one of the groups was given SRP with rinsing, and another was given the subgingival irrigation, and we found statistically significant results when the water jet was used, clinical detachment level. And the most important thing which we found out in these patients is that these patients, initially when we evaluated these patients, they were found to have a need for the surgery. And by the end of the study period, we had so much reduction of the pocket depth and attachment gain that they did not need surgery. So if you can have a patient, you can make the patient understand the importance of daily maintenance, you can actually avoid periodontal surgery, which can be a big relief for the patient. So in this study, we did find out that we could avoid surgeries in these patients. And I would like to conclude the summary of this is that the home irrigation method is safe for this part of my presentation. And we do have a significant reduction in the gingivitis, bleeding on probing depth, pathogens, and inflammatory mediators. And I want to conclude by saying a few things, that there are many technological advancements which it may not be possible for us to actually adapt all of these. And we do have to rely on our mechanical plaque control methods, or the powered brushes, ionic brushes, we can introduce them. The most important thing is that we have to have reinforcement of the oral hygiene. If the patient is not maintaining the oral hygiene, that is our failure rather than anybody else's failure. Thank you so much. Thank you for giving me this opportunity to be here.
Thank you, ma'am. Hello. Thank you, ma'am. Thank you for this wonderful lecture. I'm Dr. Parag from Department of Periodontology.
Hello.
Thank you so much for enlightening this basic topic of oral hygiene and importance of oral hygiene and the plaque or dental biofilm concepts. We all know the basic problem or the basic etiological factor of all this dental and periodontal disease, of course, is the plaque or dental biofilm. But very little attention is paid to maintenance of this or the clearance of this biofilm. Even students are aware of many students join, and in third year or by the end of fourth year, they start getting orthodontic treatment. And then they realize the importance of oral hygiene, repeated development of gingivitis and all that. and hope this lecture will solve their queries. Be motivated for this oral hygiene. A very important factor that is everybody forgets, it's a repeated oral hygiene instruction. Just enlightened. And what happens in periodontal posting or perio postings, usually after single posting, we didn't get time to give more oral hygiene instruction, but they can implement this practice in their clinical practice when they start their own clinic. Thank you for enlightening for various newer topics like nanoparticles, probiotics, PDT, that is photodynamic therapy. So this will open a window for our students for some research field like nanoparticles. They can carry out some studies regarding the control of this research. Probiotics, especially, we used to say like zehar hi zehar ko marta hai. So like the same one bacteria can be used to kill another bacteria. So this all topics, basic topics, nicely covered, ma'am. So much. Thank you so much. And I think
thank you. I would like to add one thing over here, Dr. Parag. जैसे वो बोलते थे ना, अगर रावण एक बार मर जाता तो बार बार उसको मारना नहीं पड़ता दशहरा के दिन, वैसे ही हाल हमारे ओरल हाइजीन डे का है. We have to reinforce it every year, and I hope one day people will understand the importance of that. I am very positive about it.
Yes. Everybody, when the patient comes in, we try to encourage him from scaling. So the basic answer is मैं तो रोज brush करता हूँ. So these things, this lecture may change the concept of dental students, so they can motivate the patients for the better oral hygiene and regarding the periodontal treatment. Thank you so much, madam. There are a few queries. I think Dr. Batul will just over to Batul, doctor.
Yeah, sure.
Thank you so much, sir. Ma'am, should I proceed with those questions?
Yeah, sure.
The first one is, are powered brushes better than manual toothbrushes?
See, I would like to say one thing. What I have experienced is that if a patient is able to maintain his oral hygiene with the manual toothbrush, very good. But there are patients, for example, the patients who are having some handicap, who are not able to, I would definitely recommend the power toothbrush, because in those cases, they cannot be taught, even if we teach them the proper to and fro motion of the brush and the way they should do the modified pass method, they may not be able to, they may understand it, but they may not be able to carry it out because of their limitations. It can be anybody who has any type of challenge in his life. So in those cases, definitely we should. And even then the patients who are on repeated ways, they are not able to reach very narrow areas, in the areas there where there are mal-occlusion, where the toothbrush cannot reach. We sometimes say use a baby brush in the posterior teeth, because those have small heads and they can reach the areas where the normal brush cannot reach. If they are not able to do that, definitely I would recommend power toothbrushes. And now the most important thing is that now the prices of these brushes was exorbitantly high initially, but now these brushes have really lowered a lot. So I would definitely recommend power toothbrushes to these patients. You're muted, Dr. Batul.
So the next question is, how long we should use mouthwash? Is it recommended to use it on a daily basis?
No, I would not recommend that, because chlorhexidine over a period of time has its own disadvantage. It leads to the loss of taste, it leads to staining, it leads to the formation of a layer on the mouth, and it's of course not used for a long time. See, if we are doing active periodontal treatment and we are reinforcing the oral hygiene over a period of time, the patient should be able to maintain his oral hygiene. He can use it, the chlorhexidine, for I usually say that use it till the bottle lasts and then sip. We can shift to Listerine, which doesn't have these disadvantages. If the patient is really bothered about the fresh breath and all that, we can shift to Listerine, which does not have all these side effects. Chlorhexidine is considered the gold standard, but it does have disadvantages. It should not be used more than 2 weeks.
Thank you, ma'am. Next question is by Rohan Jai Bhai. He wants to ask that his orthodontic treatment is going on since 6 months and he twice a day, but still there's a population of plaque and there's bleeding gums. So what extra precaution should he take for that?
Number 1, orthodontic brush. Number 2, Charter's method. And whatever you eat, please brush till your orthodontic appliances are there. These are the three main things what you have to maintain.
Okay, thank you, ma'am. Next question is, how effective is water floss in plaque control, and should we advise it frequently in clinical practice?
We should advise what you are talking about, jet or floss?
So floss, ma'am, floss.
Floss, floss of course is very good. The problem with the floss is that patients are not able to use it very nicely, particularly if they don't have handle. If you have to wrap it around that 9 inches, you have to wrap it around the fingers, and then people generally do it for a few months and then they don't use it. That doesn't mean that I don't recommend floss. If you're able to convince the patient to use floss, please do. But the problem with floss is that if it snaps past the contact points and goes to the papilla, it will try to injure the papilla. So you have to be very careful in instructions. You have to tell him that it has to be a controlled movement from the contact point lower than in the gingival embrasure. So if you're able to teach the patient nothing like floss, we all know as periodontists that the main disease starts in the interdental areas. We should be careful about that.
Thank you, ma'am. The next question is, does biofilm have an effect on wound healing?
Wound healing, it disrupts the wound healing. Of course, we always say that you have to clean the oral cavity thoroughly. See, if we are having a wound, you are talking about maybe a flap wound or a gingivectomy wound or something. You have to keep the area clean. This, what we talk about in the defense mechanisms, the first is the mechanical barrier of gingiva. And if we are removing the gingiva, in the gingivitis or in the flap, we are removing a part of the epithelium, it certainly makes the patient susceptible to more of the disease and the wound may not heal. So in those cases where I was telling you that chlorhexidine has to be used, because we have to be careful about having a very meticulous oral hygiene and the removal of the biofilm in these patients, so that the body has the best environment for healing. It should not, the environment itself should not create problems for the healing. So in those cases, it's very important that we use chlorhexidine.
Thank you, ma'am. And the last question is, how does biofilm affect birth weight?
Birth weight, yeah. What happens is that the oral cavity, if we see, there are many mechanisms of how it affects the birth weight. What happens in the oral cavity, we find the most prevalent organism for the periodontitis is the P. gingivalis. So it elaborates many types of toxins and the body reacts by producing prostaglandins. Prostaglandin is the mediator for the contraction of the uterine. And if the levels of the prostaglandin, usually the levels of the prostaglandin in a pregnant lady will go on increasing till the time of delivery. And at the time of delivery, it increases and it just contracts the uterus and the baby is delivered. But if the patient has periodontitis, they will have prostaglandin initially at the time when the baby is not fully grown. They will have more prostaglandin levels in their body, and that will lead to the uterine contractions. And if the baby is born prematurely, he will be low birth weight babies. That is what we call preterm low birth weight babies. So it is the mediators which are increased, IL-1 and prostaglandin, which are found in more quantities in the systemic circulation, which will lead to the with the contraction of the uterus at time when the baby is not fully grown. Again, you're not here.
There's one more question. Is it necessary to brush twice daily?
No, that's what I was saying. I don't think that person has really heard my lecture properly. I was telling you the most important thing is that ask the patient to brush when he has time. Just don't do it as a ritual. Do mindful brushing whenever you have time. If you can thoroughly, very nicely brush only once, that should be enough. But do use that time what is recommended for you. Minimum 2 minutes to maybe 30 minutes, depending upon what all is you are carrying in your oral cavity. If you're carrying periodontitis, prosthesis, you're carrying brackets and bands, you have to do it very thoroughly once. It's not twice, you can do thrice also, but one time has to be very thorough, very thorough.
Thank you so much, ma'am. So we are done with the questions.
No, there is one more question, I think. How does one having malocclusions like crowding modify their daily oral hygiene method? The more complications, the more time you have to give. Add 1 minute to each of the tooth complications. 2 malocclusions, 2 plus 2, 4 minutes. 5 malocclusions, 5.27 minutes. So that is how it works. 1 complication, add 1 minute. That's how you have to calculate.
Thank you so much, ma'am, for enlightening us with your knowledge. It was really a very wonderful session. I'm sure everyone has now far more information regarding the topic. Once again, on behalf of everybody here, I thank you for the insights today.
Thank you so much. Thank you for inviting me.
Thank you, ma'am. I would also like to express a special thanks for providing immense support to make it successful. I extend my gratitude to Dr. Parag sir, Dr. Anagha ma'am for conducting this webinar. I also thank the HODs and staff members. And I thank Aditya Paul, Ashwin Zote, and the office staff for providing us with the technical support. And at last, I thank all the attendees for making this session successful. Thank you so much once again. Have a great day. Stay safe and stay healthy. Thank you, ma'am.
Thank you so much. Thank you. Thank you, Dr. Shigli. Sir, you are not audible. Sir is not audible.
Yes, thank you so much, ma'am.
Thank you,
a lot,
thank
ma'am.
you, sir. Thank you, sir. Thank you so much.